John Wick is a 45-year-old heavy smoker with persistent cough, hemoptysis, shortness of breath, and neurological defects. Upon further testing, he was diagnosed with stage 4 non-small cell lung cancer, in short NSCLC. In fact, lung cancer is the third highest cancer type incident that happened globally. It is also the leading cause of cancer-related deaths, with NSCLC accounts for 85% of all lung cancer, most common being non-squamous adenocarcinomas. Early stages of NSCLC are asymptomatic, so patient presentation are already in stage 3 and 4, where survival rate is less than 5%. The risk factors of NSCLC are tobacco usage, occupational and environmental exposure, genetic factors, and diet. Existing treatment depends on stages of the histological profile, but most treatment has side effects. For stage 1-2 localized stage, surgery is the best cure. Stereotactic body radiotherapy may also be used. Adjuvant chemotherapy with cisplatin or carboplatin after surgery are also being used. Examples of chemotherapy side effects are hair loss, nausea, and vomiting. For stage 3, treatments include the use of chemotherapy and radiation. Radiation therapy side effects include damage of healthy cells and radiation fibrosis. For stage 4 or recurrent disease, first-line treatment includes platinum-based doublets, monoclonal antibodies, MAB such as bevacizumab with another chemo drug. Second-line treatment is a targeted treatment like alotinib or combination with MAB such as pembrolizumab. MAB such as bevacizumab has side effects such as hypertension, neutropenia, and thrombocytopenia. The economic burden of lung cancer is 1.5% of GDP worldwide. The annual healthcare in Australia is 600 million and absentee costs 325 million. The deaths in Australia is 92k, which is half of Australia's unemployment number. The QOL of NSCLC is the most intense, for example, pain increasing disability that affects their family role and social role, clinical depression and anxiety, and their caregivers are not spared from depression, severe guilt, and demoralization.
Cancer genomic landscape studies have identified 10 altered signaling pathways, including WNT beta-catenin pathway, that form the bedrock for cancer therapies today. WNT pathway is found to be dysregulated in 50 to 75% of resected non-small cell lung cancer cells. In NSCLC, ligands WNT 1, 2, 3, 3A are overexpressed and they bind to receptors FZD 1, 2, 4, 5, 7, and 8. This leads to the accumulation of nuclear beta-catenin, resulting in tumorigenic gene expressions such as CMYC and cyclin D1. This allows cancer cells to evade apoptosis and proliferation of both cancer cells and cancer stem cells. Therefore, to inhibit NSCLC cancer cells, one therapy route is to inhibit the WNT pathway. Today, there is no drug that targets WNT pathway available for patients. However, Vantictumab will soon change that. Vantictumab is a human monoclonal antibody that binds competitively to 5 out of the 6 triggered FZD receptors rampant in NSCLC. In preclinical trials and phase 1, Vantictumab inhibited tumor growth and recurrence in several solid cancer types, reduced cancer stem cell frequencies, and expression of oncogenic genes. In phase 1b and 2 on metastatic pancreatic tumor patients, Vantictumab, in combination with standard of care SOC, has showed an improved median overall survival of 10.2 months versus mono SOC of 8.5. Vantictumab also delivered significantly better overall response rate, clinical benefit rate, partial response, and stable disease than SOC treatment alone. Targeting WNT pathway with a net outcome of beta-catenin suppression has also been proven to improve cancer outlook in a few other P2 clinical trials, example curcumin and Solindet. Therefore, Vantictumab is projected to be able to deliver stronger anti-tumorigenic and anti-metastatic actions in combination use with NSCLC standard of care than mere SOC alone.
Our primary aim of the research is to measure the overall survival rate and the objective response rate. Tumor size will be measured with reference to RECIST 1.1. CT scan will be done at the end of every 3-week drug dosage cycle. Our secondary outcome will be to measure progression-free survival, duration of response, percentage of participants with adverse event or serious adverse event, percentage of patients who are still alive at the time point of every 6 months. Other data that will be collected will be the physical burden of the disease, psychosocial burden, and health-related quality of life. Confounding factors such as genetics will be taken into consideration during data analysis and stratification process. One of the side effects of Vantictumab will be bone fragility. Thus, we will be using FRAX to calculate the risk and track patient health throughout the trial. A DEXA scan will also be used to assess the bone density. Our research design will be undertaking 3 arms design, and all of it will be double-blinded. Standard of care will be carboplatin and paclitaxel. Arm A will be Vantictumab plus SOC, Arm B placebo plus SOC, and Arm C bevacizumab plus SOC. Currently in the market, the first line of standard of care today is carboplatin plus paclitaxel. Patients who qualify for bevacizumab will be given bevacizumab plus SOC as the first line of treatment. The entire bevacizumab regime consists of 4 dosage and a maintenance costing USD $359,000, excluding government support. Vantictumab will be priced at a 20% discount against the market leader bevacizumab. That is exclusive of the government discount one will receive in an individual country.
The Vantictumab phase 3 study recruited NSCLC patients in stage 3B and 4 who have not been previously treated before. The study was conducted in multiple sites across 4 regions. Stratification was done to minimize confounding factors such as gender and smoking status. Then, the patients were randomized into the 3 treatment arms, as explained previously, in a 1:1:1 ratio. Random assignment to each respective arm is performed using a computer-generated randomization program called Interactive Voice or Web Response System. This software allows for important clinical trial components such as randomization and drug inventory management to be managed. Patients in Arm A receive intravenous infusions of Vantictumab at 5 mg per kilogram with SOC of carboplatin at 6 mg per milliliter per minute and paclitaxel at 200 mg per meter square. Vantictumab is administered at every day 1 of a 21-day cycle for a total of 6 cycles. Following that, on the same day, carboplatin and paclitaxel will be administered. Arm B receives placebo, which is normal saline with SOC, while Arm C receives bevacizumab at 15 mg per kilogram with SOC, both of which will follow the same administration sequencing as Arm A. As the subjects come in for each visit, clinical assessments will also be carried out, such as CT scan and DEXA scan. Protocols are put in place to ensure that they are fit to continue the study and all inclusion criteria are adhered to. End of treatment visit occurs 3 weeks after the final cycle of treatment. This is the first dose of the maintenance with the respective singular monoclonal antibodies, Vantictumab, bevacizumab, or placebo without SOC. This 3-week maintenance cycle continues for up to 5 years, or point of PD or AE4 or death. After the EOT maintenance phase, patients enter into the active follow-up phase where we continue to track overall survival rate.
3-arm clinical trial recruited 450 participants per arm to evaluate the safety and effectiveness of Vantictumab. This amount takes into account the exclusion and dropout percentage along the course of the trial, which is 5 years. Side effects that were observed so far include fatigue, neutropenia, nausea, vomiting, gastrointestinal side effects, and bone fragility and fracture. It is essential to take note that patients with bone conditions such as osteoporosis, bone metastases, and history of metabolic bone disease are not recommended to take Vantictumab. Reports in previous trials necessitate this precaution with the fear that it might increase the risk of bone-related complication. Current safety management plan will involve doctors performing assessment of bone density before and during the course of treatment. Bone strengthening medication will also be prescribed as well. Patients are encouraged to do more strengthening and balancing exercises and keep clear of trip hazards to reduce the risk of falls. Patients will be informed of the safety information, including the risks and potential side effects of Vantictumab treatment. If patients experience any of the adverse symptoms, they will be advised to stop taking their medication and see their physician to seek immediate medical attention.